contributions you made to why we decided to do all of this. So I'll just share my screen. So are you seeing my front screen, just to double check?
Yeah, we can see that.
Perfect. And so I don't have any disclosures. My only disclosure is that I get royalties from UpToDate on unrelated information on out-of-office blood pressure monitoring. My current funding, as Swapnil mentioned, is through the National Institutes of Health. I lead 2 grants. One is related to the mechanistic management of hypertension in obese people, and mainly focused on ACE inhibitors and ARBs, which is how I got involved in this space. And my other grant is a mechanistic randomized control trial evaluating the management of hypertension in patients with heart failure with preserved ejection fraction. I will have no off-label use of any medications that I'll discuss in this talk, but I will be giving precautionary information about the uses of ACE inhibitors and ARBs de novo in COVID. So the goals of today's talk are to understand the physiologic and epidemiologic evidence underlying the original hypothesis of COVID-19 and hypertension as it relates to the renin-angiotensin system, to review the ACE inhibitor and ARB conundrum in COVID-19, how it all came about and how we got into this mess, and why there are now suddenly 83 or more research publications on this topic area in the past less than a year. And identify challenges in study design, trial implementation, and just interpersonal relationships during COVID with other researchers. And so in that context, I'll be talking about some lessons I've learned, and you'll see this slide over again, in research during the era of COVID. And so it all started what feels like a decade ago in terms of how we got here. I think that none of us obviously were expecting what was about to happen to the entire global health community last January, when all of this started in China and in Italy. I know that there were obviously from the start very disparate perceptions of how things were about to look. Many people thought this was going to be very similar to the original SARS COVID pandemic. Many others very early on speculated this is going to be as bad as what we've seen, if not worse. And I was among those who listened to the former. I was believing the messages that we were receiving in the US, that this wasn't that big of a deal, that it would be under control soon. And I decided to continue with my trip that had been planned for over a year to travel to Patagonia on March 7th, 2020. This is my Facebook post from that day, showing that we felt that we were going backpacking to pretty much the farthest point from where COVID-19 could get to us. Hope they let us back in. And while I was off the grid and had no access to any Wi-Fi or any cell service, a hypothesis was emerging. And my friends, Swapnil Hiremath, Matthew Sparks, among others, were already starting to discuss some concerns about these rumblings that were showing up in the literature. The most prominent of which was a letter published in Lancet Respiratory Medicine. And there was also a commentary that was published on BMJ's website that both very quickly made it to the press. And the question was, are patients with hypertension and diabetes mellitus at increased risk for COVID-19? And this was a very weighted and very slanted hypothesis that the authors presented, where they stated that most frequent comorbidities that are presented in patients with COVID-19 right now, again, this was back in February that this was, or late February, early March that this was published, that they were saying that those comorbidities are often treated with angiotensin enzyme inhibitor, or converting enzyme inhibitors. The authors didn't have any information yet at this point about which medications people are actually on. And I'll go through some of that in the next few slides. They noted that both SARS-CoV, the original SARS, and SARS-CoV-2 bind their target cells through ACE2, which is expressed by epithelial cells of the lung, the intestine, the kidney, and blood vessels. They also noted that ACE2 is quote-unquote upregulated by ACE inhibitors and ARBs, and they stated this is essentially as fact. And they suggested that those patients who are on ACE2 increasing drugs, such as ACE inhibitors and ARBs, are at potentially at higher risk of COVID-19 infection, and therefore we should be monitoring to see if these medications that they're on might need to be held. Meanwhile, as I said, I had no cell service. As an ACE inhibitor and ARB researcher, clinical researcher, and trialist, I was down in Chile hanging out with my husband without any access to any kind of internet. And this is where we were on March 12th when the US borders started to shut down and when flights started being canceled all over the world. And as I got to the border between Chile and Argentina, I was supposed to have about 5-6 more days, I think, or another week of my vacation. And we found out that they were holding all Americans at the border and were not letting them go home. And so we jumped off the bus that we were on, picked up another bus to the airport, and found a flight out of Chile. In the meantime, now that I had cell service, I was rigorously catching up on the about 1,000 emails that I had had from the last 4 or 5 days without cell service, and learning about this incredible collaboration that was starting. So Swapnil Hiremath and Matt Sparks led this, and this was a group of ACE inhibitor and ARB researchers as well as ACE2 experts, so bench researchers who'd been analyzing this area for decades even, all collaborated and got together to say, hey, we need to know more because very clearly something's happening here. Very clearly there's a relationship that people are talking about, and we should be the ones who are guiding this, the narrative on this. We shouldn't be letting some random letter in a journal cause speculation that shapes what happens going forward. But unfortunately, the damage had already been done, and there had already been information that had leaked. And when I got home from my trip, while furiously typing up a section of this amazing website to Swapnil and Matt, while I was flying up from Chile on my 24-hour trip home, I also noticed that I had a long series of messages that had been left from several patients of mine. And this is an example of one of them. This was a 54-year-old woman who works as an ER nurse with a past medical history of refractory hypertension and focal segmental glomerulosclerosis. Her most recent urine protein to creatinine ratio was 1.6 grams per gram. And her home blood pressures typically run in the mid-130s to 140s over 60s to 70s on 7 antihypertensive medications. I'll never forget that it was figuring out that she needed to be on that lisinopril long term, and whenever she held it, that she ended up having trouble with her blood pressure control. Not to mention, this woman had profound proteinuria and needed her lisinopril. And she had left a message on my Epic, on my electronic health record messaging system. Dr. Cohen, I've been reading about the potential interaction of ACE inhibitors and COVID-19, and I just wanted to inform you that I'll be stopping my lisinopril. I responded to her, Mrs. R, would you consider changing to an angiotensin receptor blocker? There's some evidence perhaps that there could be different risks between the two, and I'm extremely concerned about the risk of you stopping this medication that's incredibly important for your overall care. Mrs. R, again, who's a nurse, responded to me, I'd rather not take my chances. She has not responded to any messages or calls from me since March 2020 and has left my practice. And so how did we get here and why did this happen? Well, there's a lot to the story. In the US, this had a lot of gravity, that people were now spreading this concern that ACE inhibitors and ARBs could cause an increased risk of developing COVID-19 or having worse COVID-19. And this could affect about 42 million US adults, because there are almost 50 million US adults that are taking medication for hypertension, and 83% of them on an ACE inhibitor and ARB. And so first, I'm just going to briefly dive into some of the physiology that drove this hypothesis. And this is related to the information that we pooled together by this group of experts that I was very, very fortunate to be included in as a clinical researcher. And we had all of these individuals with this very intense background in the bench science and the basic research of ACE2. And so immediately we called to arms and put together the NephJC website that I described earlier, as well as several papers to do our best to try to clear up the information on this topic so people could have more of a clearer head going forward and really think more objectively about what this risk was. And so the physiologic evidence that drove this hypothesis is interesting. It's different than what we're used to hearing about when we think of the renin angiotensin aldosterone system. In medical school, we learn about how angiotensin 1 is converted to angiotensin 2 by ACE, and how angiotensin 2 is probably pro-vasoconstrictive, and that this is one of the drivers of hypertension, that this causes renal and sodium and water retention, and that this causes increased inflammation and oxidative stress, as well as fibrosis, all of which contribute most likely to increased blood pressure, as well as to target organ effects from hypertension. The ACE2 pathway we don't always learn as much about. I don't know about folks here, but we didn't learn about it in medical school, and I think in part because we're still learning a lot about it. But more and more that evidence has been very much cohesed over and over again throughout the COVID-19 pandemic. ACE2 is a counter-regulatory component of the renin-angiotensin-aldosterone system, and normally ACE2 serves as an enzyme. So throughout the literature, you'll hear it called a receptor, and this is just not the case normally. This is just a very odd thing where it turned out that ACE2 happened to be the receptor to promote intracellular ingestion of SARS-CoV-2 when causing COVID-19. ACE2 is really just usually an enzyme that actually inhibits some of those vasoconstrictive and renal and sodium water reabsorption effects and oxidative stress inflammatory effects that you normally see from the renin-angiotensin system. So normally what it does is it helps to protect us from those things that try to cause hypertension. And so there was this hypothesis, as I mentioned, based off from that article, that perhaps based on some articles that have been previously published, ACE inhibitors and ARBs might increase ACE2, and that increase in ACE2 would potentially, I'll show you on the next slide, the theory was it would potentially increase the number of receptors that exist for SARS-CoV-2, and that would allow SARS-CoV-2 to enter the cells more quickly, because the more receptors you have, the more virus can enter a cell. But there was a counter-hypothesis to this, because it's also quite possible, given that ACE2 had these anti-inflammatory effects, that this might not actually be an issue, that having more ACE2 might not be a bad thing, and if anything, more ACE2 might actually be protective against lung injury because it is anti-inflammatory and anti-fibrotic. And the latter hypothesis was actually supported by evidence from back in the days of SARS. The original SARS also uses ACE2 as its receptor to enter host cells. And there were mouse studies back when SARS had originally presented itself that found that when you have a higher ACE2, that it doesn't necessarily, in fact, worsen your risk of developing SARS or having worse SARS. If anything, it reduces it. It reduced the risk of acute lung injury, which was thought to be due to those anti-inflammatory mechanisms. And so what was the epidemiologic evidence that drove this hypothesis and caused people to really perceive that there may be this heightened risk from ACE inhibitors and ARBs? And well, this very fancy information that everybody was quoting was from the top journal, or one of the top journals in clinical medicine. New England Journal of Medicine, JAMA, Lancet, all of these incredible journals were publishing these papers that people interpreted as incredibly important, which they were, but they were overinterpreted. These were case series. These were descriptions of the people who were being admitted so far to hospitals with COVID-19. And all that these studies simply did was describe the patients. They didn't provide a control group. They didn't provide a comparison group. And so this is an example of one of them, which was one of the first studies that, case series that was published out of China, which described the patients who'd been admitted to the hospital with COVID-19. And of note, the most common comorbidity in these patients was hypertension. They also very commonly had diabetes and heart disease, as the authors noted, things that are often treated with ACE inhibitors and ARBs. However, These were case series, and we have to remind ourselves that even when published in top journals, case series with regard to the ability to infer causality or cause and effect relationship fall somewhere between expert opinion without evidence and ecological studies. These are not enough information to draw those kinds of conclusions. And the authors didn't draw conclusions necessarily in those original papers, but the speculation itself, because of the hype and concern around the pandemic, ballooned into something much more than just hypothesis. And when you look closer, it wasn't even that clear that hypertension really was a risk factor for COVID-19. And so this is an example of the first information from the US with regard to people who developed COVID-19. And this was the people that we originally had one of our first outbreaks in a nursing home. And the patients in the nursing home were, if you notice, who developed COVID-19, they had very, very high rates of hypertension. They had about 67% of them had hypertension.
Sorry, your mic is muted, Dr. Cohen.
Dr. Cohen, can you please unmute your mic?
Thank you. I don't know how that happened. Can you see my screen?
Not yet.
Now is it showing?
Yeah. Can you please go over this slide again?
Sure. Don't know how I got muted. That stinks. Thank you. So in terms of just in terms of additional data that we had from case series, this is one of the first case series out of the U.S. One of our first outbreaks occurred in a nursing home. And if you look at the information in terms of the prevalence of hypertension with regard to the individuals that were infected originally, it was very different than that study that I showed, or than the case series I showed you out of China, in that the residents of the nursing home had a 67% prevalence of hypertension. Whereas if you look at the healthcare personnel and the visitors, they had much, much lower prevalence of hypertension in those individuals. And so this tells a very different story than those original case series out of China and Italy, where it looked like enormous proportions of the people that were affected had hypertension. Now we're seeing something that's not quite in the same proportions when you break it down into different groups of patients. And if we ask ourselves what's different across these different groups, well, a key factor was the age. The older age patients, those residents, had a very high prevalence of hypertension, whereas healthcare personnel and visitors to the hospital were much younger. The healthcare personnel were on average age 40, and so consistent with what we'd expect in the population, only about 8% of them had hypertension. And visitors, the average age was younger as well, they were 63. And so this goes along with evidence that we see in terms of the general population historically, that over 75% of people over the age of 75 have a diagnosis of hypertension. And so if you have a population of patients in a nursing home, then yes, a lot of them are going to have a high prevalence of hypertension anyway, and that isn't necessarily the driving factor of why they're developing their COVID-19. If anything, we can see that obesity alternatively had an inverse relationship with age with regard to the risk of developing COVID-19. So that would make sense maybe as a more independent risk factor for COVID-19, but the prevalence of hypertension among people that developed COVID-19 and were hospitalized for COVID-19 was really very much trended with age. As people got older, which was much, much more common to see hospitalizations in older people, you saw a higher prevalence of hypertension. But it didn't matter that there were potentially some holes in this argument that had been presented, because it was too late. The damage was done. As you saw, I had dozens of messages from patients just letting me know they were stopping their medication and not willing to have a conversation about it. And a lot of this came down to the fact that the media reacted to those original papers, those original editorials. We saw all over the press here in the US that there were lay press articles speculating that ACE inhibitors and ARBs could increase the risk of COVID-19. And the second that people heard this, they were scared. They were concerned. Nobody knew anything about this virus, and most reactions were, in fact, quite reactionary. There were even hospitals in the US, some very prominent, high-quality academic centers, that sent emails to their entire faculty asking them to stop these medications in their patients until we learned more. And patients reacted to this information. In the few weeks after this information came out, when US declared the national emergency, I believe on March 12th, we saw that there was this very unprecedented and unfortunate increase in the amount of hydroxychloroquine that patients picked up from pharmacies. And a very important decrease in the amount of losartan and lisinopril that patients picked up. There was about a 10 to 20% decrease in losartan and lisinopril prescribing, which, as you noticed earlier, when you have over 40 million people on these medications, that amounts to enormous numbers of patients who stopped these medications during that time. Thankfully, medical societies reacted, and this was part of the information we collected as part of that ACE2 collaborative on the NephJC website, where we actually collated several recommendations that came out pretty quickly in early April from various international societies, including Hypertension Canada and the Canadian Cardiovascular Society, urging providers to continue ACE inhibitors and ARBs due to a lack of evidence that patients with hypertension or those treated with these medications are at a higher risk of adverse outcomes from COVID-19 infection. We really needed to get the word out there quickly, and thankfully societies responded accordingly. And it seemed that many patients were willing to restart these medications, but I'll tell you some experiences and some stories otherwise. And so what I'm going to start now is to go through some of those lessons that I mentioned in epidemiology research in the era of COVID-19. The first of which I think all of us have witnessed is this incredible, unprecedented pace of research during the pandemic, and how that impacted my research as well. And so angiotensin and coronavirus, we had this known relationship between angiotensin converting enzyme 2 and coronavirus from the original SARS and also from other coronaviruses. That there are a couple of others that use ACE2 as their receptor to enter host cells. And so there'd been prior research in this area. But if you look on PubMed, there were 233 results before 2019 and on this relationship. And it ballooned. Very suddenly, there was more than a 10-fold increase in the amount of research being done, or the amount of publications, at least, that were occurring in the area of angiotensin 2 and coronavirus, and over 3,000 studies since last February. Or 3,000 publications, I should correct, many of which are not studies and are just opinions. But thankfully, the research world also reacted quite boldly and quite quickly. There were several clinical trials that started very suddenly looking at the relationship between ACE inhibitors, ARBs, and COVID-19. I'll be talking about our study, the Replace COVID study, which was a trial that was the only international trial I'm aware of looking at the relationship between ACE inhibitors, ARBs, and COVID-19. And I'll also briefly mention Brace Corona, which was just published last week, which was the Brazilian trial looking at this. We've also been in communication with several of the other groups that are nearing completion of their trials. So we'll have a lot of trial evidence coming up soon. There are also, and so these trials, I'm sorry, that I mentioned, were all related to continuing versus stopping ACE inhibitors and ARBs in patients who are hospitalized with COVID-19. These were studies that we felt were really important because we were seeing a lot of providers not sure what to do when patients were coming into the hospital during our surges with COVID-19 and not unsure if they should stop or continue these medications, and felt that they were in quite a bit of a dilemma in terms of decision making for that. And we felt that this could really be best answered in a trial, and that this would be the question that would be really hardest to answer using observational data. There were also several trials that were started based off of that counter mechanism that I mentioned, suggesting that ACE2 may be protective in COVID-19. And so several studies wanted to leverage that mechanism, speculating that ACE inhibitors or ARBs may increase ACE2 by introducing ARBs in people that were not yet on them. And that there were several trials that were approved and started and are still underway, I believe, that are introducing de novo ARBs to patients who were admitted to the hospital with COVID-19 to see if it may help to reduce the severity of COVID-19, as well as one study that introduced it to outpatients to try to prevent hospitalization. In the meantime, what have we learned since March 2020 while these trials have been underway? So again, back to the lessons in epidemiology research that I've learned personally in the era of COVID-19. First and foremost, during COVID-19, everyone is an armchair epidemiologist. And I get back to those case series and case reports that were coming out. And I think that what I've learned is that there is perhaps no limits to the number of questionable quality papers that some high impact journals will publish during a public health crisis. I think many of us have observed this. And there were a lot more case series published after March and a lot of flawed observational studies that I think were intended with the best intentions to be helpful and help us make decisions during this fast-paced period where we didn't have better information. But I think many were done by people that weren't usually doing studies in this type of space. And I think there were a lot of issues, unfortunately, making it hard to interpret many of them. But on the bright side, more studies started to adjust for age when looking at the relationship between hypertension and severity of COVID-19. And we found that in many, many studies, hypertension fell out and was no longer a significant risk factor for COVID-19 once you accounted for age, as we speculated from some of those early case series. More so, there were so many observational studies that came out regarding the relationship between ACE inhibitors, ARBs, and COVID-19, some of which I just had one that pushed off the page, had to be retracted due to use of data that were not able to be verified or that they even existed, which is really unfortunate and a new thing that we're observing in this day and age. But there were several studies that were published in high-profile journals over the summer in June and July. And these are some examples of them from New England Journal of Medicine, from JAMA, and from Lancet, all of which were studies that would never be published in these journals during a normal period, but they really did their best to very quickly disseminate important information about these medications. And the consistent conclusion across the higher quality studies in this area was typically that there was no association between ACE inhibitors and ARB use prior to the pandemic with regard to the likelihood of being hospitalized or having more severe COVID-19. So it seemed from this information that we could conclude that it was unlikely for these medications to increase the risk of developing COVID-19. However, I will caution folks that a lot of these studies have a lot of problems with them. There is a lot of residual confounding, a lot of something called collider bias that can introduce a bidirectional bias that's very hard to interpret what direction of effect you would be anticipating to see, as well as a lot of time-dependent bias, which is something that we often don't see anymore in the literature because reviewers often really tease out those articles quickly. But we do see it sometimes, and it can be really dramatic in terms of the effect it has on the results. And this was actually what led to us continuing our trials despite this wealth of observational data that came out, because there was this big concern of the level of residual confounding and bias in them. And this is an example of one study that was published in a pretty high impact journal, Circulation Research, that has very, very wide dissemination, looking at the association of inpatient use of ACE inhibitors and ARBs in patients hospitalized with COVID-19. And the authors concluded that there was about a 64% or 66% lower risk of mortality in patients who received ACE inhibitors and ARBs during their hospitalization compared to those who didn't. And this was incredibly shockingly positive in terms of the findings. And this one was published very early. I think this was probably one of the first observational studies published. And I think that this study actually single-handedly drove several of those studies, the trials evaluating de novo ACE inhibitors and ARBs. But the issue with this study is that they counted people as receiving their ACE inhibitor and ARB, regardless of when they got it during their hospitalization. And so the study is analyzed as though everybody was assigned to either receive their ACE inhibitor or ARB at baseline, or they just were somebody who does not normally get an ACE inhibitor or ARB, or they were not prescribed it at baseline, and that they followed people until death or discharge. The problem is that people in this study could have gotten their ACE inhibitor or ARB during any time in the hospitalization. And so what that does is that introduces a subgroup of people who really would have only gotten their ACE inhibitor or ARB right before discharge, after they were well enough to survive long enough to potentially receive their ACE inhibitor and ARB. And so that basically samples specifically in the ACE inhibitor and ARB arm for people who are healthier and likely to live longer. So this is just incredibly problematic if you think of the impact of this on interpreting the results. And this always actually results in causing falsely protective results from whatever your exposure is, in this case, the ACE inhibitor or ARB, and it can do it in very dramatic ways. This is just what I think we saw in this case. And so in the meantime, we felt very justified in continuing our trial. And so this is something that we started back in March. I started writing the protocol on that plane ride back from Chile up to Philadelphia on my phone. I didn't have a laptop with me. And I couldn't be more grateful for my collaborators. From the start, we had Julio Chirinos, who's a more senior cardiologist here, was my co-PI. And Vicente Corrales Medina at University of Ottawa was an incredibly helpful collaborator in helping us think through how to overcome a lot of the challenges in how to implement a study during a pandemic. And we were originally only planning to have the trial at our 2 sites, but we ended up expanding it to 7 countries across 20 different sites. Once we realized how challenging it is to enroll and recruit patients without any funding in the course of a pandemic. And so we designed our trial to be extremely pragmatic and to try to make sure that it didn't have too much of an impact on the providers from day-to-day care. We knew that it was going to be hard to very, very quickly in March start a placebo-controlled trial. And so instead what we did was an extremely pragmatic, it was open label trial that was blinded endpoints. And so what we planned to do and what we did for every patient was that we redacted every chart so that the people determining what people's outcomes were had no idea what people were randomized to, but the providers taking care of the patients knew. And this was our way to really get it off the ground. And we had a lot of adventures, though, in terms of understanding how to design and implement this trial that was really unlike any other in such a rapid time period, given how quickly information was affecting patient care early in the pandemic and still now. And so a few lessons I do want to just go through just in the last few minutes are during the COVID pandemic, we really found that everyone's an armchair ethicist and just some of those unique challenges in designing a study during a pandemic. And so first off, it was how do you even include patients in a highly pragmatic trial like this, where we early on in the pandemic, when we started this trial, masking wasn't a thing. I was going into my patients' rooms when I was on COVID service, and they were telling us there's no reason to wear a mask for the first several weeks. And it was something that we really wanted to make sure, though, that we were protecting our research staff and that we were doing this in the most efficient way possible as well, given how important it was to get this information as quickly as possible. And so what we ended up doing was something called eConsenting, which didn't exist before the COVID pandemic, and I don't understand why, at least in our systems in the US. And so we actually developed a system where we could actually text message our patients the consent, and we had 2 verbal witnesses on the phone with the patient asking their permission to enroll them, and that they were able to actually provide their signature just in the form of an ID number, because we didn't have any kind of technology in place to be able to allow someone to do one of those very cool electronic signatures. And so this was the best that we could do. And it worked, and we ended up getting our full enrollment of patients by August, so between March and August. And though in the meantime, we did encounter a lot of barriers in enrollment, and part of why we had to expand to so many centers was that it was taking longer to enroll than we expected, because there were so many ebbs and flows in terms of the surges of which which hospitals had higher rates of COVID at any given time, and also challenges in recruiting. It wasn't just the patients that we had challenges in recruiting during the pandemic, though I think there was a really exceptional fear of research and science that was more so than what we ever really encounter in terms of recruiting for other types of trials, but also the providers. The providers were really very, very opinionated and very concerned about what it meant for their patients to be in this kind of a trial. And so we received responses from people along the lines of, don't you think it's unethical to continue lisinopril in a patient with CKD, with chronic kidney disease, who's admitted to the hospital? And then 20 minutes later, I would call somebody and get the opposite response. Don't you think it's unethical to stop the ARB in somebody with chronic kidney disease who's admitted to the hospital. This could be at the same hospital that I would have two providers in the same specialty giving me completely opposite concerns and refusing to let us approach their patient because they felt that it was unethical to randomize them to continue or stop their ACE inhibitor or ARB, but for the opposite reason. There was a lot of concern from providers about how to engage in this kind of pragmatic research. What do I do if my patient becomes hypotensive? And it was written into our protocol that providers had full reign. So we were randomizing patients to a treatment strategy, but if a provider felt that their patient's health would be impacted by stopping or continuing the medication respectively, that they needed to go forward with whatever they felt was best from their clinical judgment. And so we had a lot of counseling of the providers to just pretend that once the patient's assigned to one or the other, try to adhere to it, but you're not held to it. And lastly, we had a lot of people who would take over care of patients and transitioning between different COVID services who didn't feel comfortable with the previous team having agreed to take part in the trial. And so we actually had a couple of people that crossed over because a new team would take over and would tell us that they don't feel that it's ethical to continue to hold somebody's ACE inhibitor or ARB, or alternatively to stop it, or to have them on it. And we actually had someone say that they didn't want to hold it and they restarted it because of the very, very impressive evidence that losartan likely improves outcomes in patients with COVID-19. And they referenced that article that I showed you earlier that had horrible measurable time bias or time-dependent bias that was likely falsifying those results. But they felt that that evidence should be guiding our treatment of these patients. But ultimately, we succeeded, and we randomized our 152 patients that we needed, which sounds very small, but I'll go into why that was sufficient. And we ended up with 75 people assigned to continue their ACE inhibitor or ARB and 77 assigned to discontinue their ACE inhibitor and ARB. We had a substantial number of crossover events, which we expected because it was such a pragmatic study. So there were 17 people who were assigned to continue their ACE inhibitor or ARB who ultimately stopped it. On average, that was about 5 days after their initial randomization, which to us isn't that surprising because that's also about the same duration of follow-up as a little bit shorter than the average duration of hospitalization. And so we think that this was sort of some of the really sicker people at that point were being transferred to intensive care units, and that was around when that occurred. There were also 7 people whose ACE inhibitor or ARB was restarted before the end of their hospitalization. Often it was because they were about to be discharged or because there was one case in somebody who developed new onset reduced ejection fraction who hadn't had one previously and whom they were restarted on an ACE inhibitor or ARB for that reason. And then the reason that we were able to do such a small trial, we purposely selected this type of an endpoint because we knew that we were really under the gun in terms of time, that we had a short period of time to answer this question and that we really needed a very efficient way to do it. And so we used something called a global rank score. And a global rank score simply ranks people by how sick they are. And then you compare the average rank between the two treatment groups. And the reason that this is so efficient is that unlike in other types of endpoints, this is considered what's called a continuous non-parametric endpoint. You don't have to remember that from your stats lessons and epidemiology lessons back in the day. But the reason this is helpful is that you're not looking at a yes-no question and you're not looking at certain set parameters. You're really just ranking people by how sick they are and looking at the overall sickness between the two groups. So we ranked people by how long it took until they died. So people who had the shortest time to death among those who died were ranked first. Then we ranked people based off of how long they were mechanically ventilated or in an ICU, based off of how long they might need to be dialyzed or on a vasopressor, and based off of how severe their multi-organ dysfunction was. So if they had elevations in creatinine or how much time they needed oxygen for, as well as how long they were in the hospital for. And overall, what we found was that there was no meaningful difference in the global rank score between the two treatment groups. You can see the distribution varied a bit, but we take that into account by doing the analyses in a very specific way that considers those different shapes of the groups in terms of the distribution of how sick they were. But overall, it was the same across the two groups, or relatively, or close to the same across the two groups in terms of the severity of illness in those people who continued their ACE inhibitor compared to those people whose ACE inhibitors or ARBs were stopped during their hospitalization. We also found no difference in all-cause death at 28 days, and we found no difference in ICU admissions or mechanical ventilation at 28 days. Additionally, as a nephrologist, I was really excited to see that we saw no difference in creatinine during follow-up. There were 3 acute kidney injury events in each treatment arm, in the group that continued and the group that stopped the medication. And the mean creatinines over time were the same across both groups. The mean potassiums were also the same across both groups, though there were 2 people who had potassiums over 5.5 in the continuation group during follow-up, whereas the discontinuation group didn't have any events with the potassium over 5.5. So there is a slightly higher but not significant risk of hyperkalemia from continuing the ACE inhibitors and ARBs, but it looked like there wasn't necessarily, at least in our cohort, an increased risk of having acute kidney injury or worsening kidney function. Complementary to our study, the Brace Corona study was a Brazilian study that just was published in JAMA last week, and they found very similar results. One concern that we really had with this study is we were surprised it was actually put out in a really high impact journal. The authors did an amazing job, and much like us, there were a lot of barriers to overcome to quickly randomizing this many patients. But they did end up having 11% of their cohort was actually discontinued from the study after randomization because they had violations of good clinical practice. They actually had one site where over 70 patients were included in the study that never consented to take part in the study and collected their data for several days, if not, I think, weeks before somebody realized that this had happened. And so that does a lot in terms of how you interpret the results of a study, but they don't really go into that a lot in their study. And this is very similar to a lot of what we're seeing in COVID, where there's just a lot of things happening very quickly and people aren't really taking the time to take a step back and really think deeply about why. But I think it doesn't really matter because in the end we have the same conclusion that there was no difference in terms of the risk of continuing or stopping ACE inhibitors or ARBs. So I'm really reassured that I think that based off of this in the context of some of the higher quality observational evidence, that there really doesn't seem to be a relationship between ACE inhibitors and ARBs with COVID-19. And this is supported by better quality mouse evidence. There now has been published data from Dan Batye. He was one of the members of the consortium, the ACE2 consortium with the NephJC website, where they demonstrated that in mice, lung, and kidney tissue, that ACE2 is not increased when you give a mouse both an ACE inhibitor or an angiotensin receptor blocker. So it looks like ACE inhibitors and ARBs probably don't impact ACE2 where it counts, and they really might not impact ACE2 at all. ACE2 is really hard to measure, and we suspect that a lot of the studies in the past that had shown that ACE inhibitors and ARBs increase ACE2 may have had issues in terms of their measurement of some of these parameters. Myself and Dr. Torino and Julio Chirinos, my co-PI from the Replace COVID study, we actually published a proteomics study also that had found that ACE2 levels were not impacted at all by ACE inhibitor and ARB use in patients with heart failure, for example. There is some remaining hypothesis and questions to be answered. For example, there's this bradykinin storm hypothesis in COVID-19. It's felt that the ARDS and the other adverse findings that we see in severe COVID-19 are probably not related to cytokine storms, though there's some controversy over that. And there was a really elegant study that was published last year that suggested that there could be a bradykinin storm that's actually contributing to these findings in COVID-19, though there hasn't been a lot of supportive evidence to uphold it. So I think we need more information in that area. But if that is the case, and if we do find that this upholds, it could be that ACE inhibitors and ARBs actually have different effects on COVID-19, and that a lot of what we're seeing in terms of the lack of difference between people stopping or continuing their ACE inhibitors and ARBs could just be related to the fact that more people now tend to be on ARBs than ACE inhibitors, and the studies weren't adequately powered to look at the difference between these two classes. And so more information may be upcoming on that area, but we do know that ACE inhibitors reduce the breakdown of bradykinin and that bradykinin can increase the risk of inflammation and acute lung injury. And so in summary, there are a lot of challenges in terms of hypertension management in COVID-19, and I think that it was an adventure for a lot of us in terms of very quickly starting a study and just how to manage patients during this time period and how to deal with this tumultuous, constantly changing information. I think important lessons to take away is that it's really easy to be an armchair epidemiologist and ethicist when you're dealing with limited information, because it makes it's simpler to draw conclusions when you don't know what you don't know. So just try to always think about that when having strong opinions one way or another about any decision during the pandemic, because we're working with two hands tied behind our back half the time. I think that pandemics really do bring out some of both the best and the worst in medical publications and medical journalism. We saw people really call to arms and very quickly volunteer to do incredible international trial work in several areas. But we also saw a lot of people very quickly just publish a whole lot of opinions that have a lot more weight than people realize and that might not have been fully based in fact. And we've learned about new information about renin-angiotensin system blockade and COVID-19, that there's likely no association of ACE inhibitors and ARBs with the risk and severity of COVID-19, and that they likely actually don't even increase ACE2 expression, at least where it counts, in places like the kidney and the lung, where we know are very, very heavily impacted by COVID-19. Premature or unnecessary discontinuation of these medications really can elevate the blood pressure and the risk of decompensation of issues like chronic kidney disease and CHF. So I think that it's really responsible that so many of these medical societies very, very quickly called to arms also and made these statements stating to stop doing it. And I'm so incredibly grateful for all the work that Swapnil Hydermath and Matt Sparks put into the NephJC website to make sure that this was being disseminated very quickly to a broad audience. That website, I forgot to mention, it had over 300,000 views in its first 2 to 3 months of when it had started. And so clearly there was a lot of interest in this area, and it was really an honor to be part of disseminating hopefully some better quality information than what was out there. And last off, I would not suggest de novo initiation of ACE inhibitors and ARBs for treating COVID-19 at this time. I had given talks all over the summer and the fall where people were still asking me, why aren't you starting it in these patients? I've been starting losartan in as many people as I can, thinking that it's actually preventing them from getting COVID-19. And it's incredible to me how much people took away from, again, limited evidence and really stood by it, thinking that they were actually helping their patients, where I'm a very big proponent of using these medications when medically appropriate, but not for the treatment or prevention of COVID-19. So thank you so much. I'm very, very happy to take questions now.